Tips for nursing around vancomycin management. Vancomycin is an acidic antibiotic that has the risk of extravasation when administered peripherally. Using small gauge catheter in a large peripheral vein can help avoid extravasation. When possible, central administration of vancomycin is preferred. If extravasation occurs, stop and discontinue the line. Gently aspirate but do not flush the line. Vancomycin can never be administered intramuscularly. Always double check that the correct reconstituted dose was drawn from the vial. Here at Sioux Lookout, Menoyawin, the programmable IV pumps have vancomycin-specific infusion rates for varying doses saved in the library. In all situations, the rate is to be less than 17 milligrams per minute. For example, 1,000 milligrams of vancomycin can be infused over 60 minutes. 1,001 to 1,500 milligrams can be infused over 90 minutes. 1,501 to 2,000 milligrams of vancomycin is to be infused over 120 minutes, and 2,001 to 2,500 milligrams vancomycin is to be infused over 150 minutes. Alternatively, these rates can be manually entered based on the volume of the bag. Rapid infusion of vancomycin may lead to flushing of the skin, red rash on the face, neck, and chest. Quick infusion may also cause itching and hypotension, known as red man syndrome. When this is observed, nurses are to stop the infusion immediately and contact the prescriber. Antihistamine may be considered prior to the dose infused. Vancomycin-associated nephrotoxicity may prolong hospital stay, requiring additional antibiotics leading to higher cumulative costs, and sometimes may escalate to dialysis treatment. In very rare cases, mortality may also occur. Risk factors for nephrotoxicity include dose and duration of vancomycin. Therefore, serum trough concentrations are measured regularly. However, evidence around trough concentrations being associated to effectiveness of the antibiotics are less convincing, meaning primary purpose of trough concentration is to monitor side effects. Vancomycin is cleared by the kidneys. Higher creatinine will require longer dosing intervals. To avoid nephrotoxicity, nursing can help by monitoring thirst, lower urine output, darker urine, nocturia, dry skin, or peripheral edema. If patient is not fluid restricted, offering water 8 times a day may also help avoid nephrotoxicity. Monitoring for tinnitus, vertigo can also help avoid permanent ototoxicity. Being suspicious of higher volume of television or radio are worth noting. For vancomycin to be effective and safe for the patient, the antibiotic's blood concentrations are collected 30 minutes before the 4th dose is infused. This is known as trough levels. If troughs are less than 10 milligrams per liter, contact the prescriber, as these concentrations are not effective against the infection but instead increase resistance rate. May continue infusions if troughs are between 10 and 15 milligrams per liter. Granted, the infection being treated is a skin and soft tissue infection, for example, cellulitis with MRSA. Meanwhile, if patient is being treated for endocarditis, meningitis, osteomyelitis, sepsis, or severe pneumonia, troughs between 10 to 15 milligrams per liter are not appropriate and require contacting the prescriber immediately. Troughs between 20 to 24.9 milligrams per liter put the patient at higher risk for nephrotoxicity and ototoxicity. Therefore, contacting the prescriber is necessary. And troughs greater than 25 milligrams per liter require holding the dose or stopping the current infusion immediately, in addition to contacting the prescriber. Additionally, if serum creatinine doubles or estimated GFR reduces by 50% from patient's baseline, contacting the prescriber is also necessary. Within the medical directive of SLMHC, nurses may order vancomycin trough levels and serum creatinine levels before the 4th dose is administered or before the 3rd dose is administered in the event that the patient's current dosing interval is every 24 hours or longer. Please note, new methods of monitoring vancomycin via area under the curve are currently under development by healthcare practitioners. Therefore, continued education around this topic should be anticipated. As seen, routine monitoring of serum vancomycin concentrations requires time and nursing resources, and therefore is not cost-effective. One approach to reducing vancomycin use is to prevent methicillin-resistant Staphylococcus aureus infection, also known as MRSA, in the community and in the hospital. Nurses can help to educate patient upon discharge to practice hand and body hygiene at home by using soap and water often, by keeping wounds clean and covered. Nurses may instruct patients to avoid sharing personal items at home, such as towels, razors. If an infection is anticipated, getting care earlier will also reduce community-associated MRSA rates. In the hospital, practicing policies and procedures related to infection prevention by all staff, for example, assuring hospital rooms and medical equipment are carefully cleaned, along with washing hands before and after seeing the patient with soap or alcohol sanitizer, treating infection appropriately and quickly, and by educating patients to stay in their rooms unless for a test or a treatment, to avoid infections spread while admitted, are all strategies that help prevent hospital-associated MRSA.